This video will cover Chapter 24 on cerebral palsy. The objectives for this section are to understand the basic pathology of cerebral palsy, to know the difference between the classification levels 1 through 5, and we'll go through those, and understand basic treatment for cerebral palsy. So cerebral palsy, or CP, is a non-progressive lesion of the brain that occurs prior to the age of 2, and it results in disorders in posture and voluntary movement. The incidence rate ranges from 1.5 to 4 cases per every 1,000 births within the U.S. This data is from the CDC in 2008. CP is most commonly classified by muscle tone. It can also be classified based on the distribution of the limbs involved or the functional skills or abilities of the individual. Now, the cause of CP is unknown, but it is suspected to be multifactorial. Disabilities associated with CP, 80% are suspected to be the result of factors occurring before birth, and 20% are suspected to be the result of factors occurring at birth or within the first 4 weeks of life. So essentially, injury that can occur that results in CP most likely occurs before birth. The basic pathology of the condition results in brain damage caused by cerebral anoxia, can be caused by hemorrhage, or malformation of the central nervous system. Our clinical manifestations include motor impairments. This can be poor motor control of the head, the neck, and the trunk. We can also see delayed motor development. We'll also see poor force production of the muscles and poor control, and often persistent reflexes and increased tone. Risk factors for CP, there is a table in your book, 24-2 on page 727, I believe. This lists the different prenatal, perinatal, and postnatal risk factors that contribute to CP. Now, I tried to abbreviate this a little bit. There is a box in your book. It is box 24.1 on pages 725 and 726. This is the Gross Motor Function Classification System, so the GMFCS, that is used for patients with CP. And this is based on their functional status and their need for assistive devices or wheelchairs. So essentially, the classifications are either a level 1, 2, 3, 4, or 5. And the main idea is that with level 1, this includes children with neuromotor impairments, but their functional limitations are a little bit less than what is typically associated with CP. Whereas on the flip side of that, at level 5 is much more severe, requiring constant assistance, and typically requires assistive devices or a wheelchair. So a level 1 is fewer limitations, higher functioning, and level 5 is more severe limitations and more severe restrictions and requires more assistance. Now, the classification is also grouped by age. This is done because mobility at different ages, as we know from growth and development, is going to be different in each age group. So the very first group here, less than 2 years, if we look at these children, we know that crawling, mobility, and walking in healthy children will occur before the age of 2. In our children with CP, typically, if they're not walking at this point, that would allow us to classify them. So tasks that we're going to look at for their function are going to include sitting, crawling, rolling, and that will give us our classification. When we get to our older ages, ages 2 to 4, 4 to 6, 6 to 12, healthy children are doing higher level activities. So it's easier to classify children compared to their healthy counterparts at the same age to what they should be functioning at. So for the exam, I'm not going to ask you to identify what a level 2 between the ages of 4 and 6 is going to be functioning at for a child with CP. That's extremely complex, and that's something that if you specialize in pediatrics, you may have to do. What I want you to understand about this concept here is that level 1 versus level 5. I would also recommend that you get a general understanding of what motor milestones or activity levels or functions children should be at, or healthy children would be at, in each of these age groups. So we said less than 2 years, these children will typically be ambulatory. They'll be able to sit, roll, crawl, all of those sorts of activities. Ages 2 to 4, children will be independent with walking and ambulation. They may be running, jumping, so those sorts of activities. So I would review that for each of the different age groups. So we may see some musculoskeletal impairments in children with CP. Some of that often includes altered muscle tone, muscle weakness, and joint restrictions. This image here is from your book on page 729. This is an x-ray of a pelvis. It's an anterior to posterior view. The vertical lines that we have here should be right through the middle of the head of the femur, and the vertical lines are on the outer edges of the acetabulum. So here's our horizontal line here, and our vertical lines should be through that acetabulum. So what we see is if the head of the femur is too far lateral from the acetabulum, which we see here. So here's our acetabulum, and here's the head of the femur. It should be directly through the middle point. So this is a little bit too lateral. There's going to be an increased risk for hip dislocation. And contribute that with increased muscle tone and spasticity, that will also increase the risk of dislocation. So typically, with increased spasticity of our hip flexors, that will result in a dislocation of the hip. So treatment for children with CP should be family-centered. Understanding the needs and values of the family is important, and involving the parents is key because they are the primary caregivers. So I will say it again, and a very important component of treatment for children with CP is that it should be family-centered. It should involve the parents. Assessing passive range of motion will also be important for these patients. The treatment that we will do working on passive range of motion is to get the trunk to move and to work in diagonal and rotational type patterns. We can work on linear motions, flexion, extension, things like that, but they won't be as functional. Oftentimes we will prescribe orthoses for these patients. The idea is we want them to be as ambulatory and mobile as possible, but we don't want to provide too many restrictions on them. So things like an AFO, an ankle-foot orthoses, will provide stability and support and decrease the amount of effort and energy that they use. Strength training will also be beneficial for these patients. It's going to aid in their mobility and their trunk stability, which will help with sitting, standing, and walking balance. Assistive devices will benefit these children. However, we want to pick the device that is the least restrictive so that the child can play and participate in activities, but still provide the most support and be functional. So these are some examples of medical equipment for children with CP. So on the left here, this is called a Mulholland walkabout. Don't worry about the terms, I'm just providing them for extra information. So the benefit of this device is that it allows the child to propel themselves and play, and it gives extra support. However, the support is posterior, so she can still play with everything in front of her. The top right here is a powered wheelchair. This can increase in height and allow the child to elevate closer to the height of a table so they can reach countertops and other surfaces. On the bottom, we have a computer device that helps with speech generation. So the way that this device works is this child will tap the device on the left side here with their cheek, and that will allow her to scroll through the numbers and letters and create the message that she wants to share. On the left here, these are examples of our AFOs, or ankle-foot orthoses. Okay, they will help provide support and stability, but they're also going to improve alignment, and repositioning these patients often helps to decrease their muscle tone. In the middle here, We have another chair. This is called a Tilton Space. And what this chair does is it angles backwards, and it allows for pressure points to be redistributed to areas that we don't want to break down and cause pressure sores. This individual also has increased spasticity in the shoulders, so this brace over the top will help hold the shoulders in place and again try to decrease that tone. These two on the right here, these are standing frames. These allow for supported weight bearing. There is a seated sling here around the pelvis. This does provide support. And there is also a shoe holder here at the bottom that helps keep them in an upright activity. So this allows them to be upright and weight bear and still perform activities because of the table in front of them and still participate with other children.